Surgery of the Ear, Glasscock and Shambaugh's, Edition 6, Chapter 28, Tympanoplasty, Tympanic membrane repair. Introduction. According to the American Academy of Ophthalmology and Otolaryngology Subcommittee on Conservation of Hearing 1965 definition, tympanoplasty is a procedure to eradicate disease in the middle ear and to reconstruct the hearing mechanism with or without tympanic membrane grafting. This procedure can be combined with either an intact canal wall CICW or a canal wall down ICWD mastoidectomy to eradicate disease from the mastoid area. The original tympanoplasty classification system of Wolstein is used presently only in the vernacular of otology, example a type 3 mechanism or a type 1 tympanoplasty. History. The term tympanoplasty was introduced in 1953 by Wolstein to describe surgical techniques for reconstruction of the middle ear hearing mechanism that has been impaired or destroyed by chronic ear disease. The same year, Zollner reported on surgical techniques for improving the sound conduction mechanism of the middle ear following surgery for chronic ear disease. 1 year later, Wolstein had described an operation for repairing tympanic membrane perforations with a split thickness skin grafts. Another major contribution of these two otologists was the introduction of an operating microscope in performing otologic surgery, which improved their results significantly. Tympanoplasty can be considered the final step in the surgical conquest of conductive hearing loss and represents the accumulation of over 100 years of evolution of surgical procedures on the middle ear to improve hearing. The first of these procedures was the stapes mobilization of Kessel in 1878, soon followed by Berthold's plastic repair of a perforated tympanic membrane in the same year, and Kieselbach's attempt in 1883 to correct a congenital meatal atresia. These very eventful years might well have been the beginning of a fruitful development of operations for conductive hearing loss, for the mechanism of the middle ear had been defined clearly by Helmholtz shortly before in 1868. However, despite the early successes with stapes mobilization reported by Bochron in 1888 and Miotte in 1890, the new surgery for deafness declined and by the end of 19th century died out as determined opposition by the leaders in otology had arisen against all attempts to improve hearing by operations of the middle ear. The strong opposition to surgery for deafness was reflected in the standard text of otology and otologic surgery, which scarcely mentioned or mentioned only to condemn such operations. For example, Kerrison's 627 page Diseases of Ear, published in 1930, devoted less than a single page to surgical measures for relief of deafness, concluding that these operations, mentioned for their place in otological history, are quite obsolete today. It is even more surprising that Sir Charles Ballance, in his two-volume text, fails to mention any sort of operation to improve hearing. Reasons for the opposition to reconstructive surgery of the middle ear were no doubt the lack of surgical microscopes, imperfect sterilization techniques, and the absence of protective antibiotics, possibly resulting in infections and other iatrogenic injuries. There were few reports of serious infections following the early operations, but one can surmise that some very unfortunate unreported results contributed to the opposition. An additional reason for the skepticism for operations to improve hearing may have been the lack of audiometers for quantitative measures of hearing before and after surgery. Probably the greatest reason for the lack of interest in reconstructive operations on the ear was the intense preoccupation of the otologists of those days with infections of the ear and their complications. It is interesting that Schwartz described the simple mastoid operation just 3 years before Kiesel mobilized the stapes. And Kuster, Goffel, and Stack described the radical mastoidectomy at early, exactly the time that Boucheron and Miot were reporting success with stapes mobilization. It is evident that the climate of autologic, though, was favorable towards procedures to control infection and quite unfavorable towards operations on the ear to improve hearing. The revival of interest in the surgery of deafness began when Holmgren's, with considerable courage in the face of the concerted opposition, began his long series of operations on labyrinth for otosclerosis, demonstrating that with modern methods of aseptic technique, the non-infected mastoid process and labyrinth could, after all, be opened safely. The surgical application of the operating microscope, first by Nyland in 1921 as a monoocular instrument, and then by Holmgren's, who introduced the binocular operating microscope in 1922, was an important advance destined to play an increasing role in the perfection of fenestration, stapes operations, and tympanoplasty. Soldine's ingenious and successful tympano-labyrinthopexy for otosclerosis is added to the reviving interest in surgery for deafness. The real turning point in the reorientation of otologic surgery away from operations of for infection towards reconstruction of the hearing mechanism occurred when Lampert combined Soldine's several stage operations into a more practical one stage fenestration operation. At this time, sulfonamide therapy of acute otitis media and otitic complications had begun to lessen the urgency and frequency of operations for acute mastoiditis. Lampert emphasized careful aseptic techniques in the post-operative period as well as during the fenestration operation, with the latter addition to the sulfonamides of prophylactic penicillin, post-operative infections lost much of their threat. Most important of all, Lampert taught his operation to otologists from all parts of the world. It was inevitable as the number of patients successfully treated by Lampert and his pupils increased to hundreds and then thousands that the traditional and often bitter opposition started to decline. Thanks to Lampert, the climate of otologic thought finally became favorable towards surgery for deafness. This led first to the successful operations for congenital meatal atresia in 1947 by Pate and Ombrende, and finally to revival of stapes mobilization by Rawson in 1953. It is remarkable fact that during all these years, clinicians and surgeons failed to see clearly the applications to surgical techniques of the principle of middle ear sound pressure transformer as described by Hellhorns, Holmerger, Holgrams, Solly, and Lampert had no clear idea of how the fenestrated ear functioned and why the fenestration operation could not restore hearing to normal. Likewise, Petty and Omberende failed to appreciate the need to restore sound pressure transformation by placing the constitute tympanic membrane in the contact with the mobile stapes. The mechanism of the fenestrated ear remained obscure until Beckesi and Dewars began to study this problem. Dewars in 1948 noted that the tympanic membrane of the fenestrated ear must be intact to protect the round window somewhat from sound pressure. 2 years later, Davis and Walsh defined the residual conductive hearing loss after successful fenestration as being due to loss of the impedance matching mechanism of the tympanic membrane, ossicular chain, and oval window. The two basic principles of tympanoplasty had now been defined, namely sound protection for the round window and sound pressure transformation for the oval window. It is interesting and surprising that tympanoplasty techniques for chronic otitis media began in Germany rather than in United States, where fenestration surgery had reached a high degree of maturity and perfection. In 1950, Moritz first described the use of pedicle flaps to reconstruct a closed middle ear cavity in cases of chronic suppression to provide sound shield or protection for the round window in preparation for the latter fenestration of the horizontal semicircular canal. The principle of Moritz's procedure were immediately apparent. Zollner in 1951 and Woolstein in 1952 began reporting of similar operations to provide sound protection for the round window and to reconstruct sound pressure transformation for the oval window. Early on, Woolstein advocated free skin transplants rather than pedicle grafts used by Moritz and Zollner soon after changed from pedicle to free grafts as well. The subsequent development of tympanoplastic techniques had gone through major changes. Soon after the introduction of split thickness grafts, it was realized that the accumulation of keratin debris and the associated infections resulting in failures made their use impractical. Zollner replaced the free distant skin grafts with meatal skin removed as free full thickness grafts. Weighing as grafting material was reported independently by Shea and Tabb in 1960. Temporalis fascia was described by Herman in 1961 and was introduced in United States by Stoss in 1963. Plastic processes for reconstruction of the ossicular chain were tried early on and abandoned by Zollner and Wolstein. However, they continued to be used in United States both for tympanoplasty and stapedectomy. Soon after, the tendency towards rejection and exhaustion of the plastic processes used in tympanoplasties and stapedectomies were evident became evident. Following these initial failures, it was soon realized that the wire prostheses made of stainless steel, platinum, or tantalum were better tolerated in the middle ear. Ossicular repositioning was described by Hall and Reitzner in 1957. Homografts ossicles for reconstructing the ossicular chain in tympanoplasty became popular in the early 1960s. Glasscock and House reported their first largest series of homograft of tympanic membrane procedures in 1968. Biocompatible ossicular processes such as total ossicular replacement processes TORPs acting as a columella from the tympanic membrane to the oval window and partial ossicular replacement prosthesis PORP connecting the stapes head to the tympanic membrane have been in everyday use during the past 25 years. During the past 25 years, otologists have used numerous types of ossicular prostheses made of various allopathic plastic materials such as plastipore, proplast, polyethylenes, polytetrafluoroethylene, ceramics, Teflon, and hydroxyapatite. Um, Ossicular chain reconstruction is presented in chapter 29. Types of tympanoplasty according to Wolstein. Type 1 with restoration of the normal middle ear. Type B. Type 2 ossicular chain partially destroyed but preserved and continuity restored. Skin graft laid against the ossicles after removal of the bridge. C. Type 3 Myringostepedopexy producing a shallow middle ear and a columella effect. Type 4 round window protection with a small middle ear mobile foot plate left exposed. E. Type 5 closed middle with round window protection, fenestra in the horizontal semicircular canal covered by a skin graft. Physiology of middle ear. When animals emerged from sea to onto land, dry land, a mechanical device was needed to overcome the air-water sound barrier. The middle ear mechanism developed from the discarded bronchial apparatus no longer needed for breathing, which was the answer. By means of a rather large hydraulic ratio of the large tympanic membrane acting on a small stapes footplate combined with a rather small lever ratio of longer handle of malleus acting onto the slightly shorter long process of incus airborne sound vibrations of large amplitude but small force are transformed into fluid borne sound vibrations of small amplitude but large force. Becchesi calculated the effective vibrating surface of tympanic membrane area compared with stapes foot plate area to be 17 to 1 and lever effect of the oscillator chain 1.3 to 1. The 17 to 1 hydraulic ratio and the 1.3 lever ratio yields a total increase of pressure at the oval window of 22 times. This is termed the sound pressure transformer ratio of the normal human ear and equates to approximately 27 decibel gain. The round window in the normal ear acts as a relief opening at the opposite end of the cochlear duct from the stapes footplate to permit maximum to and fro vibratory movements of the non-compressible cochlear fluid column in the rigid bony cochlea. In the normal ear, the round window membrane movements are largely passive in response to the stapes footplate movements. This is partly because the 22 times pressure increase at the oval window far exceeds any competitive pressure exerted on the round window from the tympanic cavity side. Furthermore, the round window membrane movements are largely passive in response to the stapes footplate movements because of the intact membrane tympanic membrane protects the round window from competitive sounds partially by damping and partially by a phase difference.